Now let's discuss diffuse cortical necrosis, which is generalized infarction of the cortices of both kidneys. It's caused by things that cause disseminated intravascular coagulation, because that's going to make little clots in the microvasculature of the kidneys, leading to those diffuse infarctions and necrosis. So things that can cause that are obstetric catastrophes such as abruptio placentae, where the placenta, let's say this is the placenta, separates from the uterine wall. It can also be caused by septic shock, where there's disseminated intravascular coagulation as well as vasospasm. And both of these lead to small infarctions in the cortices of the kidney. So if this is the kidney and we have our medulla here and here's our cortex, there's going to be a bunch of little infarctions all throughout the two kidneys due to these little clots in the microvasculature. Next we have acute tubular necrosis, which is the most common cause of intrinsic renal failure. The interesting thing about this disease, however, is that it is reversible in some cases, but it can be fatal. And when it's fatal, death occurs during the maintenance phase. And we're going to talk about what I mean by maintenance phase in a second. Now, acute tubular necrosis is usually caused by ischemia or toxic injury to the kidney. The ischemic injury can occur during hypotension, shock, sepsis, hemorrhage, or CHF. And the nephrotoxicity can occur from things like aminoglycosides, radiocontrast agents, lead, cisplatinum, crush injury, leading to myoglobin clogging the tubules and creating reactive oxygen species, as well as hemoglobin, which can also damage the kidneys through a similar mechanism. Now, both ischemic and nephrotoxic injury lead to the death of the tubule cells, usually the proximal tubule and thick ascending limb cells, because they are the most metabolically active. Hypotension, shock, sepsis, lead, hemoglobin, proximal, and thick ascending limb, most metabolically active. As the tubule cells slough off, they appear in the urine as granular muddy brown casts, and this will tip you off on the exam to acute tubular necrosis, the muddy brown casts. You can see these cells will be sloughing off. So there's three phases of acute tubular necrosis. First is the inciting event, and this is followed by the maintenance phase, which usually lasts 1 to 3 weeks. This phase is oliguric, meaning the patient does not generate much urine. If this is the case, what will the patient be at risk for? They'll be at risk for hyperkalemia and metabolic acidosis, since potassium and hydrogen ions can't be excreted. And death most often occurs during the maintenance phase. During the recovery phase, the patient excretes the fluids and substances that have been building up, so this phase is polyuric. BUN and serum creatinine levels fall back to normal. There's a risk of hypokalemia due to overexcretion of potassium. Usually, if patients can get through the maintenance phase, they recover very well during and after the recovery phase. Next, we have renal papillary necrosis, where a papilla of the kidney infarcts and sloughs off. And this occurs when a person with an underlying risk factor has an infection or an immune stimulus that affects the kidney. And this can lead to gross hematuria as well as proteinuria. So the area that is at risk for the infection or immune stimulus causing renal papillary necrosis is sensitive to hypoxia. That's why it's at risk for papillary necrosis. But why? And the reason is because the papilla is the farthest away from the blood supply. Because remember, the arterioles are coming from the cortex and they're coming down through the renal pyramids and going to the papilla. So the papilla is the last place to receive the oxygenated blood. And that's why it's the most sensitive. Now, the underlying risk factors for patients to get renal papillary necrosis include diabetes mellitus, acute pyelonephritis, chronic phenytoin use, and sickle cell anemia or trait. So patients with any one of these diseases who then have an infection or immune stimulus can then have renal papillary necrosis. Now let's talk about acute kidney injury, which is also known as acute renal failure. Just like the term heart failure, where the heart is not able to meet the demands placed on it, renal failure is the condition of the kidney failing to meet the demands placed on it. This means that the kidney is not able to adequately filter plasma, and this causes azotemia, which is the rise in BUN and creatinine in the blood. When you think about causes of renal failure, it's best to think about them in terms of what exactly is preventing the kidneys from performing their function. This splits AKI, acute kidney injury, so I'll refer to it as AKI. It splits it into three categories: pre, intrinsic, and post. Pre-renal, intrinsic renal, and post-renal failure. So first, let's look at pre-renal. Pre-renal essentially results from decreased renal perfusion to an otherwise normal kidney. So remember, in this case, the kidneys are normal, but there's decreased perfusion, such as during hypotension. So the GFR decreases, and the kidneys attempt to conserve blood volume. And the term kidney injury here is actually a little misleading because the kidneys are not actually injured. They're just failing to filter the plasma adequately because not enough plasma is coming to them. This leads to an increase in the BUN to creatinine ratio. Why? Because creatinine continues to be actively secreted while BUN gets reabsorbed with sodium. So in cases of low blood volume, there's increased BUN reabsorption, but creatinine continues to be secreted. Next is intrinsic renal, and this is where there is actual damage to the kidney. And the GFR here is not due to decreased blood being delivered to the kidneys, but actually the kidneys are damaged themselves. And this can be during things like acute tubular necrosis or glomerulonephritis. And the necrosis leads to debris obstructing the tubules, and then the kidneys are unable to excrete the waste. And the urine will have granular casts, and this time both BUN and creatinine excretion are impaired. However, BUN is normally reabsorbed in greater quantities than creatinine is secreted. So, what that means is that intrinsic renal damage actually leads to a decrease in the BUN to creatinine ratio, because BUN reabsorption has a larger impairment than creatinine secretion. Next, we have post-renal AKI. which results from some kind of urine outflow obstruction. But again, here the kidneys are normal. And urine outflow has to be obstructed bilaterally, because if urine is only obstructed from one kidney, the other kidney can compensate and produce the urine that needs to be produced to clear the body's waste. Postrenal AKI is usually easy to detect because abnormalities that cause it are anatomical and can be detected on CT or ultrasound. So in order to have postrenal azotemia, urine flow has to be obstructed bilaterally. Now let's look at some lab values that will help you distinguish the different types of renal failure. Now it can look a little intimidating, but let's walk through it and you'll see it's not so bad. So if urine osmolality, that's the first thing we're going to look at, is higher than 500 milliosmoles per kilogram, then we know it's pre-renal, because the kidneys are appropriately trying to concentrate urine, and they are. If urine sodium concentration is greater than 40 milliequivalents per liter, then you know that the renal failure is either intrinsic or post-renal, because here the kidneys are unable to reabsorb sodium and it's being excreted in the urine. Normally, kidneys try to hold on to most of the sodium and reabsorb it. The next variable we look at is the fractional excretion of sodium, which is the percentage of the sodium filtered by the kidney which is excreted in the urine. So it's the excreted sodium divided by the filtered sodium. And this is really important for distinguishing the different types of renal failures. So let me ask a question. An abnormally high fractional excretion of sodium, such as greater than 2%, means what exactly? It means that the sodium is being filtered through the glomerulus, but it's not being reabsorbed properly by the tubules. So that means there's a problem intrinsic to the kidneys, or it can be a severe case of postrenal failure. Finally, the serum BUN to creatinine ratio can tell you whether the renal failure is pre-renal, because the ratio will be greater than 20 if it's pre-renal. And if it's less than 15, then it can be intrinsic renal, or between 15 and 20, it's post-renal. And remember that in intrinsic renal, the BUN creatinine ratio is low because the kidneys are failing to reabsorb BUN. Let's do a flash quiz. A 45-year-old man is hospitalized for hip surgery. 2 days post-op, he becomes oliguric. His blood work is notable for a serum BUN of 40 mg per deciliter with a serum creatinine of 1.3 mg per deciliter. Which of the following therapies would be most helpful? Antibiotics, IV fluids, or furosemide? If you said IV fluids, you're right. This patient has acute renal failure, which you can tell from his oliguria, and he has an elevated BUN to creatinine ratio. The fact that his BUN to creatinine ratio is greater than 20 means that this is pre-renal. And remember, pre-renal is when there's decreased blood flow to an otherwise normal kidney. And since the problem is decreased perfusion, the best treatment would be to give that guy some IV fluids and replenish his blood volume.